Thank you, Mary Margaret, and thank you for giving me the opportunity to speak to this group today. Again, my name is Paul Reynolds. I'm with Kindred Hospice, and today my goal really is just to go over hospice in a general terms. I'm not a clinical person. I don't like to have a clinical discussion. I think there's a lot of misconceptions about hospice, so I'd just like to talk about some of those and just kind of talk to you about how hospice works and answer some basic questions that people often ask. The first thing that I want to talk about is you'll hear the words palliative care and hospice care used interchangeably, and they are not the same thing. Palliative care can begin at diagnosis and during treatment to help with comfort care, pain management. Hospice is available for folks when whatever the disease is that we're dealing with, in this case, stomach cancer, you're not fighting that disease anymore. So it's more about treating the patient than the disease itself. So that's kind of the differentiation. Again, palliative care can deal with pain management or symptom management during treatment. Hospice care is when treatment has been stopped and you're really just looking at purely quality of life for the patient. So those are the two differentiators. I want to talk a little bit about some of the misconceptions, some of the misunderstood things about hospice care. I will say that when I first meet with families or patients, when you say the word hospice, everyone is taken a little bit aback. So it's really the first part of my discussion with someone is talking about what hospice is and where their mindset is. There are people that can often benefit from hospice services, but they're just not ready psychologically for that. So we kind of talk with people about what hospice is and how it can support them. So there is kind of for some folks, there's a bit of a mindset shift there that needs to happen. It's a very personal decision. So part of what I do is talk to people about what that means and seeing where they're at. And if some folks aren't ready to go on hospice services, we just wait until they are and kind of educate along the way. The goals of hospice are symptom management, pain management is part of that. And it does buy people more time. Medicare did a study in 2007 of about 4,500 people that received hospice services, and the average benefit in time was about 29 days of extra time. And I think for some people that's very important. Obviously they can complete some important tasks during that time. They get more time with loved ones. So although the goal of hospice is not to increase or decrease time of life, it's more about quality of life, there is a benefit in time of, again, about right around 29 days. And that time, for a lot of folks, they'll call that the hospice gift, just to have that time to get things taken care of. Again, more time with loved ones. It's very important for a lot of folks. I'll talk a little bit about some of the misunderstandings. Some folks think that agreeing to hospice care or even looking at hospice care is giving up, and that is certainly not the case. We are called in when the benefits of treatment for disease are no longer effective. And so now we're really looking again at quality of life and just having the highest quality of life with the time that you do have left. So it's not giving up. And some patients feel that way, and even families sometimes they'll have conversations with people and they feel like, well, gee, my mother, my father, whoever the loved one is giving up. So that is not the case. It's really just doing the best you can with life you have remaining. Some fear that, we all fear death. I fear death. It's a big subject. Folks think that they will be in pain throughout the last time of their life, and that is not necessarily the case. We do a lot of folks, again, pain management, comfort care, that's what we do. So that is not the case in most cases, actually. Hospice, people have the misconception that hospice is a place. It is not. There is one hospice provider in King County that does have a standalone hospice building. They can handle about 14 patients. But generally, hospice is provided wherever you reside. That could be your home, assisted living community, skilled nursing, hospital. Wherever you are, that's where we go to provide services. So again, think of that. Think of hospice as a service as opposed to a physical building. Some people are also confused about or are reluctant to talk about hospice. They think that they need to wait for their physician to bring that or another healthcare worker to bring that subject up. I tell families, bring it up anytime you want more information about hospice. So it's common for families or the patient themselves to just reach out and ask your physician about hospice, what their thoughts are, and then they can contact us or give you information about who to contact, and then just open that discussion. I will say that one of the things I run into is people wait too long to get that information. It's nice to at least get some basic information like I'm sharing with you today early on, so that later, if families are stressed, patients stressed, you've had that initial discussion. It's not such a scary subject, and you can be a little more informed and have more control over how things go. Something else, another misconception is people think that they cannot retain their current primary care physician. That is not the case. People do most often retain their current physician or physicians if they have specialists. We really kind of just come in and offer support to that team. We do have a medical director who is a physician that's available to your primary care physician, and sometimes we do take the front seat, but generally not. We're just there in a supportive role to support your current healthcare team. Hospice, some people worry about the expense of hospice care. It is covered 100% by Medicare, generally covered by Medicaid, and most private insurance providers also have a hospice benefit, so you certainly want to check into that. But it is typically, there's no cost to patient or family for hospice care. I want to talk about some frequently asked questions, same on the same thing. There will be some redundancies in this, but I just want to make sure I cover things. I think we're clear on what hospice is, that it is treating the patient rather than the disease. The goal is quality of life, pain management, symptom management. That's really what we're after. You'll hear, I don't know if any of you heard this, that hospice is for those that have a terminal diagnosis with an outcome of 6 months or left to live. That is a guideline that Medicare looks for, but that's certainly not, it's not written in stone. And many patients on hospice outlive that 6 months. And that's something that we see often, and that's not a disqualifier for hospice services. We have a gentleman right now who's been on services with us for 2.5 years. So he still has a terminal diagnosis, obviously, but don't let that 6-month number kind of stick in your head as absolutely necessary. That's just something that Medicare looks at. And the kind of the terminology they use is that someone has 6 months or less to live if the disease takes its normal course. So it's a little vague there. There's some leeway there to work with. So the team that is involved or available to hospice patients include, of course, your physician, as I mentioned, our medical director, who is a physician. We have an RN case manager that oversees everyone's individual care. The person that, or people that will provide that care, that specific care, are our certified nursing assistants, our CNAs. So those are the people that are actually providing the hands-on care to folks. We have social workers available for family and for patients. Spiritual folks are available, and we also have volunteers. The volunteers are available for any non-medical kind of help that you may need. If it's not uncommon for maybe husband and wife to be living at home, husband's on receiving services, the wife just needs some time to get out, do some shopping, maybe just take a mental break. Our volunteers can come in, spend time with the patient, read with them, watch a game. They can do some lighter housework, maybe cook a meal, have a meal with them, that sort of thing. There is also respite service available under the hospice benefit, and that is if maybe there's a business trip that someone needs to go on, a spouse needs to go on, or some other longer term stay, we can have someone move. If they're in their home, they would go to skilled nursing for up to 5 days. We'd care for them there. The spouse or whoever the other loved one is can take care of whatever they need to, and then they can come back and resume the care at home. So that's a real nice benefit for people. Hospice, those team players, not everyone is involved in every case. Some folks won't take advantage of the spiritual person. They may not take advantage of the volunteers, but they're there for people if they need us. When people do come and visit hospice, something that hospice is not, is it's not 24-hour round-the-clock care. It's intermittent services, very specific services, which will be determined during the initial evaluation and care plan. So, and family members, patient will know what that care plan looks like. That is a living, breathing document. So as care increases or decreases, we make those adjustments. People do graduate off of hospice. So if someone is doing better, they can opt out. That does not curtail their benefits in the future. They can come back on hospice later at any time. So you do see that happen. Our services are available 24 hours a day, 7 days a week. You always have 24 hours, 7-day nurse availability. Our medical director is available. Social workers are available. So if it's the middle of the night, there's maybe a pain management issue or something else, you can always call us. We're available, and we respond accordingly. I did mention earlier that hospice can be provided in any setting, so that's important to know. Again, home, assisted living, skilled nursing, even hospital, wherever those services are needed, we come to patients and provide that care there. You do not have to be homebound. Occasionally I'll have people say, well, gee, don't I need to be homebound to receive hospital or hospice services? That is not the case at all. There's a gentleman we're working with now who still drives. So he gets out and about, but he's also using the hospice benefit. So you don't have to be homebound. We talked about payment, so that that's covered. One thing to remember, that patient rights do not change when someone's on hospice services. They have the right to, again, go off of services, go on services. So there's no change there. It's always up to the patient as far as if they want to stay on hospice or not, hospice services or not. And that's really, it's a brief talk, but I just wanted, that's kind of the general overview of what hospice is. And that's really it, all I have today. Thank you for your time.